Growing older is a process all of us experience. It begins when we're born. In our first 20 years or so, we see it as a positive. We're growing up and maturing. We become adults. Our lives are busy completing our educations, developing our careers, raising our children, building our friendships. But the clock keeps ticking, and we continue aging. All of a sudden, we're middle-aged, and then some. There are clues that time is taking its toll. We can't read the phone book without glasses anymore. We can't get away with late nights followed by early mornings. We can't run upstairs the way we used to. We can't remember things quite as well. And we can't ignore all those little aches and pains from time to time. We wonder, am I just getting old, or is there something wrong? Maybe something seriously wrong. As nurses, it's important to know the effects of normal aging on the physical and mental status of our patients. And it's even more crucial to recognize changes that are not normal, diseases or pathological conditions. Normal aging and its implications for nursing is the topic of this module. It's one of a series of study modules on nursing approaches for quality care of the elderly. I'm Shirley Cudney, a faculty member of the Montana State University College of Nursing. Let's meet our first speaker. She is Dr. Margaret Heikemper, who takes us on a physiological tour of the body, noting the changes that take place with advancing years. To begin, she tells us about her academic background and research interests.
All right. I'm an associate professor in the Department of Physiological Nursing at the University of Washington in Seattle. I have a BSN in nursing from Seattle University, a master's in nursing with a specialty in gerontological nursing from the University of Washington, and a PhD in physiology and biophysics from the University of Illinois at the Medical Center in Chicago. I've been in Seattle at the University of Washington since 1981. My area of research is in gastrointestinal physiology. In geriatrics, I've worked in both long-term and acute care geriatric settings.
Sounds like you're just the ideal person to talk with us today. I guess the first question that comes to my mind, and maybe of many, is it possible to live to be 200 years old?
Well, that would be nice. When we look at longevity, we can look at it in two ways. The first is the concept of maximum longevity. What is the maximum lifespan that we as a species are going to live? Man has the longest lifespan of any of the animals, but it seems to be limited to somewhere between 110 and 120. There are certain groups of people in the world that apparently, on an average basis, live to be that age, but that's not very typical. Most of us will never reach our maximum lifespan because of disease, illness, accidents, and a number of other factors. What we tend to look at more realistically is the mean longevity, the sort of average lifespan for a given group of people. And that has been steadily increasing over a number of years, so that people born today are more likely to live longer than people born 50 and 60 years ago. So when we look at what is the potential for living longer, it's in the area of increasing the mean longevity. And of course, as nurses, what we care about most is increasing the quality of those years as we live longer. Not just the fact that we're living longer, but that we have a high quality of life during those years.
In other words, we want to stay healthy till we die.
That's right. That's
okay. Okay, then there is a difference really then between normal aging processes and pathological problems. And I would imagine it would be important to try to determine which is which.
That's true. It's very difficult to look at normal aging changes because as we get older, the incidence of a number of pathological processes increases. And it's difficult to separate out what is truly normal aging versus what is pathology. Part of the problem has been in the way that the research has been set up. We have a problem in that most studies are done on a cross-sectional basis. That is, that different groups of people are examined. For example, people in their 20 to 30 range are compared with a group of people who are between 60 and 70. What we really need are longitudinal data, studies on groups of people who are followed throughout their lifespan so that comparisons can be made. Because you always have to consider environmental factors, genetic factors, other things which may be contributing to this process or these age-related changes.
Now, generally then, can you tell us about some general age-associated changes?
Well, if we think about aging from a real, very general perspective, we think of it as being very gradual process, and that it doesn't occur magically when we turn 65. That physiologically speaking, many of the age-related changes begin in the third and fourth decade, and we'll be talking about a few of those later on. Aging is very individual. People do not age at the same rate. Everyone has a sort of individual aging pattern. Different organ systems do not age at the same rate. We see perhaps more age-related changes in certain organ systems of the body, whereas others remain relatively intact till quite an old age. What we can say is that complex systems and functions show the most obvious change. That is, the integrated functions of the body seem to show the most change earlier on. We know that vulnerability to diseases increases as we get older. And finally, that the threshold for stress appears to change as we get older, our ability to adapt, to deal with the environment.
Well, I don't know if there's anything more you want to talk about in that area, but are there some reasons why the body ages?
Well, that's quite a complex question. There are a number of researchers looking into that whole phenomena of why does the body age? What is the etiology or etiologies for that? When we look at aging processes, we have to think of them as meeting certain criteria. An aging theory should include the fact that aging is a universal phenomena, that it is a progressive one, that it is intrinsic, that it's not due to something in the external environment, but that it is a truly intrinsic process, and that in the long run, this aging process will be detrimental to the organism itself. Now, there are a number of theories which have been proposed to explain why it is that animals age, and we can look at these or categorize them as random versus program theories. Now, when we think about random theories, there are a number of ones which are proposed. And these include the error catastrophe theory, which was proposed back in the 1960s by a man named Orgel. This theory basically says that aging is a big mistake, that as we get older, we get accidents or mistakes in our ability to repair faulty proteins, that we have proteins which are synthesized, which are not as good as the proteins that we once synthesized. And as a result, this sort of produces an exponential problem where one faulty protein results in another and another and another. And in the long run, that will be detrimental to the organism. Now, there are some people who propose this. It's very difficult to actually study this theory. It's somewhat conceptual. If we look at the process of going from DNA to RNA to protein synthesis, we have a number of built-in safeguards to make sure that errors don't occur. And there are enzymes which are involved in this process. These enzymes do not appear to change that much with aging. So this theory probably does not account for true age-related changes, but it does account for some of the things that we see in people exposed to intrinsic factors like chemicals and ionizing radiation, that these people who do appear to have accelerated aging do have faulty protein synthesis, perhaps. Another random theory of aging is that as we get older, we accumulate substances in our body, in our cells, which will be detrimental. An example of this is the accumulation of a substance known as lipofuscin. Lipofuscin is a brown pigment substance that if you were looking at cells histologically, you would observe in nearly every cell type of the body. And it's thought that this substance, as it accumulates, may be detrimental to normal cell processes such as transport. But even though there is a linear relationship between age and the accumulation of lipofuscin, the actual mechanism whereby this is creating age-related changes is not known. Another random theory would be that as we get older, we get an increase in what are known as cross-link formation between various molecules. And the easiest way to look at this is to think about elastin components in arteries, that these are very stretchable. but that as we get older, we get cross-links forming between these elastic components, which will then decrease their elasticity, so they will not stretch as well as they did when we were younger. And we can think about cross-link formation occurring in a number of different cell types and organs where stretch and elasticity would be very important. A fourth random theory is that as we get older, we accumulate what are known as free radicals. Now, free radicals are a normal consequence of many enzymatic reactions. That as you're going from one compound to another, you may have the generation of free radicals. And that these free radicals, if they were to remain in that state, would be detrimental to lipid substances, which would be in cell membranes, so that over the long run, having a lot of free radicals around may destroy cell membranes and hence produce cell death. This theory, while is interesting, is another one that's very difficult to prove because free radicals are an intermediate step in a chemical reaction, and they're very, very difficult to measure. So it's hard to actually prove that free radicals accumulate in cells as we get older. But because this has been hypothesized to cause aging, some people have looked at the use of antioxidants, which decrease free radical formation, as a possible means of decreasing the aging process. Now, on the program side of things, I've discussed things that are sort of random and occur rather spontaneously. We can look at aging as being very programmed within each individual cell of the body, that perhaps there is a finite capacity to the number of times that our cells are going to divide. And this theory was first proposed by a man named Leonard Hayflick. And he found that if you took skin fibroblasts and you put them in culture medium and allowed them to divide as many times as they wanted to, that there would come a point when those cells would no longer divide. That there would seem to be something in the genetic makeup of those cells that limited the number of cell divisions that they would go through. Now, this theory has gone through a number of elaborate experiments where they've done things such as transplanting nuclei from old cells to young cells and determining that it does reside, that the programming element of this process is in the nucleus of the cell. They've also done experiments utilizing cells from individuals who have the accelerated aging diseases such as progeria and Werner syndrome, which are marked by very aggressive aging, that children are born and they age by the time that they are in their teen years. And it found that these cells have a change in the number of times that they divide as well. Another offshoot of the program theory of aging is that the programmer doesn't reside in individual cells, but rather resides in the central nervous system, that there are cells in the central nervous system that act as a biological clock, that once we reach a certain point, that this clock changes and it causes disruption in both the nervous system and in the endocrine system. So it's thought that perhaps at the level of the hypothalamus or above that, that there is a biological clock that lets us know when we've perhaps lived long enough. A theory which I should also comment on is a theory called the killer hormone theory, which is sort of a very dramatic name for an aging theory. And this theory says that as we get older, we release a substance from our pituitary gland, which blocks the action of thyroid hormone at the tissue level. Now, this theory was based on the observation that many older people look like younger people who have hypothyroidism, that they have the change in metabolism, they have problems with mentation, intolerance to cold, bradycardia, a number of things that we associate with our older population. But when we measure thyroid hormone levels, as we'll talk about later, we don't see a real change in normal aging in thyroid hormone levels. So the thought is that we have this pituitary substance which acts at the level of the receptor to block the action of thyroid hormone, so it's as if we are hypothyroid. This theory has not been proven and will require actually identifying what the substance is from the pituitary gland before it's actually accepted as a true aging theory. But it's something that you might come across when you're reading about theories of aging.
Well, it sounds as though we grow old for some reason, but those are pretty sophisticated ideas as to why that happens.
Well, let me point out, too, that most people think it's probably not just one of those things, that it is a combination of perhaps 2 or 3 of those different theories working together to produce aging, that not just one of them alone cannot account for the sort of age-related changes that we see in every organ system of the body.
Although we're trying to make an effort to distinguish normal aging from pathological processes, we'll have to face up to the notion that there are some diseases that we seem to be more prone to as we get older. Is that true?
That's true. If we look at what people die of, I mean, not that aging should always be correlated with dying, but we are progressing to that point. We notice certain diseases are much more prominent, and of course this is cardiovascular disease, cancer, cerebrovascular accidents, and then the infectious diseases, pneumonia.
Dr. Heitkamper reviewed several theories used to explain the aging process. She also pointed out the difficult task of distinguishing between normal aging and pathological processes. In an earlier workshop, Dr. Heitkamper made an interesting comment about the cellular growth of an elderly person. She explained that at the cellular level, the replacement process changes as we get older. In our early years, new cells are exact duplicates of the old cells. But in elderly persons, the replacement cells are more heterogeneous than homogeneous. In other words, the new cells are not quite the same as the ones they replace. What does this mean? Let's consider the liver. If the replacement cells are not entirely the same as the original cells, the function of the organ may be altered. The liver may not work as well because it's not the same or as efficient as when we were younger. Dr. Heitkamper covered a lot of material on aging theories. Let's take our first R&R break, review and relaxation. There are study questions in the booklet to help you remember key points. After the break, our discussion continues with information on the nervous system and how its structure and function change as we age. You can stop the tape now. I hope the review questions were helpful. The answers are on the next page in the booklet. Remember, if one of your answers was not quite on target or you drew a blank, you can replay the videotape to study what was said, just as you would reread an article in a journal or a chapter in a textbook. Our topic now is structural and functional changes in the nervous system. Many of us are very aware of functional changes as we age. Our eyes may no longer focus on small print without reading glasses. Our hearing may not be as clear as before. Our favorite foods may not be as tasty as we remember them. Our ability to smell a beautiful flower may not be as acute, and our sense of touch may not be the same. These functional changes and structural alterations in the brain itself are discussed now by Dr. Heitkamper.
Well, when we look at the nervous system, we should start by looking at it very grossly. What happens to the brain as we get older? If we look at the brains themselves, the first thing that's always observed is that brain weights decrease with age. And this is based upon cross-sectional studies again, where the brains are simply weighed from a group of people who are 70 to 80, 80 to 90, and compared with a group of individuals between 20 and 30, 30 and 40. And when you compare those two cohorts, you notice that the brain weights of older individuals weigh less than those from younger individuals. However, it's also brought up that we have to take into consideration that body size has changed over since the turn of the century, and that people are getting taller and getting bigger, and that this factor also needs to be considered, that, to use the word rather loosely, that evolutionarily we have changed, and that this may not be that we're actually have a decrease in weight, but that as a species, our body size and everything else has changed to influence brain weights. What we do know is that as we get older, we do appear to lose neurons. And you remember that neurons are the functional unit of the central nervous system, and that we do lose the number of these cells that we have in the brain. Now, if we look at normal aging versus pathology, we say that all of us will lose neurons, and this begins again in the third and fourth decade of life. And that as long as we lose them rather diffusely from a number of different areas of the brain, that they shouldn't account for any significant functional change. What we do see pathologically is when people lose a significant number of neurons in one or two anatomical locations. An example of this would be in individuals who have Parkinson's disease, who lose a large number of dopaminergic neurons from the basal ganglia. And when you lose a large number of neurons from one specific anatomical location, you're going to see functional changes. But you have to be real careful when you're talking about loss of neurons, because we can attribute a lot of behaviors and stereotypes based upon this observation that we lose neurons. The body is wonderfully redundant. When we lose something, we adapt, and we adapt by making changes in what we have left. So we see some adaptations occurring in the nervous system as we lose neurons to sort of compensate for these losses. And we'll see that in other tissues as well. As we lose neurons and the brain matter, another observation that sort of follows along with that is that the ventricles in the brain become larger, that the size increases. And this is noticed on x-rays or CAT scans or a number of other tools, that the ventricles become wider. Now, this might have some clinical significance in that older people who have a brain mass, be it a hematoma or a tumor, may not show symptoms as early as a younger person because they have more room for that mass to enlarge before they're going to show the symptoms of increased intracranial pressure, because the ventricles are wider and more room for a tumor to grow. So it's something to keep in mind. A fourth thing that's looked at in relation to aging changes in the brain is the blood-brain barrier. The blood-brain barrier is the purpose of it is to keep certain molecules out of the brain, of the nervous tissue, and to separate it from the general circulation. And it's thought that perhaps as we get older, that this blood-brain barrier becomes less effective, and we are not don't have protection against certain things which might be in the circulation, which may be detrimental. This has not truly been validated yet. It's more been hypothesized that this may occur. We do know that as we get older, our cerebral blood flow decreases quite markedly. That's typical of most organ systems. As we get a decrease in cardiac output as we get older, our organ perfusion decreases, and cerebral blood flow decreases as well.
And those are the major changes in the nervous system. Are there others that?
Well, those are the major changes in the structure, if we were to look at it rather
the
gross.
structural part.
The other thing that we have to look at when we're looking at the nervous system are the individual cells, the neurons themselves. How do they change with age? And there are some quite distinctive changes that occur in them. We see a higher amount of what's known as neural axonal degeneration, that some axons degenerate as we age. The other thing we notice is that there is a loss of myelin being the insulating material that surrounds the neurons, which aids in the speed of conduction of an impulse. So if we lose myelin, one of the consequences would be is that impulses traveling up the axons would take longer. So we might see a decrease in reaction time, a decrease in information processing occurring. In the cell itself, may see a decrease in number of microtubules, which are involved in cell transport, an increase in lipofuscin, like we've talked about before. And then there are two rather unique characteristics to neurons, and those are an increase in what are known as senile plaques and an increase in neurofibrillary tangles. These two structures inside the cell, while we don't know really what they do functionally, are a normal characteristic of aging, and qualitatively or quantitatively, they're used to look at people who have dementia. That in dementia there seems to be an increase in these two intracellular components. That while we all have some of this occurring in our neurons, that individuals who have dementia seem to have a higher number of these two, constituents inside the cells.
As we suggested earlier, the senses are affected by normal age changes, including vision and hearing. Dr. Heikemper says distinctive changes are in store for us as we age.
It's expected that if we all lived long enough, we would have severe visual impairment. But in relation to normal age-related changes, there's a condition known as presbyopia, which is characterized by an inability of the eye to accommodate for close vision. That as we get older, the point at which we can bring things up to the eye to clearly see them becomes further and further away. And that's a normal age-related change. And so for many of us, when we get to be 40 or 45, we start needing glasses to read. There are other things that occur in the eyes in relation to aging. One is that the pupil size decreases. And that has to do with how much light we're going to be able to take in. And so as we get older, we're going to have problems in going from light to dark. And you'll hear people talking about how they have problems driving at night and those sorts of things as well. They also have an impairment in the ability to gaze upward. So upward gaze is affected. The thing to keep in mind here again, that visual changes occur over many years and that we all compensate until we sort of reach a threshold where we can no longer compensate for that. Another condition which we see quite frequently in older people is an arcuus senilis, which is a gray circle around the iris, and what it means functionally we don't know, but you may see that in some of your patients. One somewhat pathological change, which most people view now as a normal age-related change, is the formation of cataracts. If you remember the lens, we can think of it as almost like an onion that has many layers over it. And as we get older, we continue to form layers over the lens, which ultimately will decrease in the transparency of the lens. And so that not enough light is getting through and is going to cause visual impairment. And for many individuals, cataract removal is a typical type of surgery to go through.
Dr. Heitkamper also reminds us of another problem that aged persons have. The lenses of our eyes are controlled by a group of muscles that alter the shape of the lens when we look at nearby objects or things in the distance. The ability of the muscles to control the lenses appears to decrease with age. The result, she says, is that our eyes can't focus an image on the retina as well.
Now there are some other common problems that are more pathological in older individuals, and one of these is glaucoma. And the incidence of glaucoma increases as we get older. And in the older individual, you remember that there are two types of glaucoma, acute and chronic, and the type that we're most likely to see in our older patients is chronic glaucoma, which is due to an decrease in the outflow of aqueous humor, which bathes the outer portion of the eye. And so patients need to have their intraocular pressure checked on a regular basis to see if this is occurring. We also know that intraocular pressure increases as systemic blood pressure increases. So in older individuals who have a problem with hypertension, this may be need to be checked a little more frequently. Another condition that you might see in the older patient is a problem of senile retinopathy, which is sort of a degeneration of the retina, which is where the sensors for vision are, and that in certain individuals it occurs bilaterally. It's not really treatable, but the retina decreases, and this will have a significant impact on vision, because without the retina you don't have your receptors, and then vision is markedly decreased.
Sometimes then our patients tell us, well, my doctor says there's no sense in changing my glasses because it won't help. Would this be an example of a condition that might be related to that problem?
Exactly, because once nerve damage has occurred, it's permanent and it's not going to be altered. Whenever you have damage to the neural elements involved, it's not going to be correctable by glasses.
The condition Dr. Heitkamper just referred to, senile retinopathy, is seen functionally as low vision. The problem of low vision is addressed in another module titled Sensory Perceptual Alterations in the Elderly. It features Dr. Linda Phillips of the University of Arizona, who shares some excellent examples of low vision. The illustrations were prepared with the assistance of Mary Opal Wolanin, who is featured on other tapes in this series. The sensory perceptual module also has practical information on overcoming hearing problems. Changes in hearing with age is the next topic discussed by Dr. Heitkamper. I asked her if it's true that all of us eventually lose some of our hearing as we grow older.
Well, it's not that generalizable. What we can say is that there are some normal age-related changes in hearing, and this is a condition known as presbycusis. And two characteristics of this is decreased ability to hear a tone, certain tones, in particular high-frequency tones, and this is going to decrease their ability to discriminate speech. So they're going to have these two particular characteristics as a normal age-related phenomena. Older people do complain more of hearing changes, and for those of us who care for the elderly, we know that this is also true. So it tells us that perhaps what we need to do is to speak very clearly to our older clients, that we need to stand in front of them and face them when we speak them, because many people, as they begin to lose their hearing, will make some compensations along the way, and they won't even be aware of it. Many people learn to lip read without even being aware that this is what they're doing. So we have to be very cognizant of these normal age-related changes in hearing when we're dealing with older clients. Some people benefit very much from hearing aids, which we see quite commonly in older individuals. We have to keep in mind that hearing aids do not amplify all frequencies, and so frequently people with older people with hearing aids will complain about distorted speech or distorted hearing when they're wearing their hearing aid, and some individuals will not be real compliant about always using this. Should point out that there are some very common problems, not exactly normal age-related change, but very common problems with the hearing system in older people. One is that as we get older, the soft tissue in the external ear becomes looser. And what that's going to mean is that wax that builds up in the external ear may get trapped and may be more difficult to remove. This will result in what we call a conductive hearing problem. Another problem is that the bones in the middle ear may degenerate. The three little bones that transmit sound from the tympanic membrane to the inner ear may degenerate. Another problem is the tympanic membrane, which is made out of elastic tissue because it vibrates in relation to the sound waves, becomes less elastic, that there may be crosslink formation occurring, which makes it less elastic. So there may be decreased hearing because of changes in the tympanic membrane as well. And then finally, we have to look at the inner ear and look at the sensory receptors for hearing. And there may be changes in the fluid which circulates around in the inner ear, changes in the metabolism and ionic composition that occurs that may influence hearing, as well as the little receptors themselves, the hair cells, may change somewhat with aging, producing more of a sensory neural hearing loss.
Well, after hearing, I think probably the one I was kind of wondering about, and that there seems to be some controversy about, is whether or not smell changes with age.
Yes, that's an interesting question about smell, because we don't really know. It's a very difficult sense to monitor or to test. What we can say is that indeed older people do show some decrease in ability to discriminate various odors and smells, and that they may in fact have decreased sensitivity in this particular sense, but it's not as well studied as the other special senses. What it does tell us, though, is if older individuals do have decrease in smell, it may make them at risk for safety in case of fire. And another problem might be smelling contaminated food may make them more vulnerable for taking in food that has spoiled and leaving them more susceptible to enteritis due to eating contaminated food. We probably know a little bit more about what happens in relation to taste sensations as we get older. And we have to keep in mind that taste and smell are very much interrelated. And we do know histologically that the number of taste receptors in the mouth do decrease with age, that the number of taste buds do. Studies that were done back in the 1940s and 50s showed that for men there is an increase in the threshold for salt perception, that it takes more salt to give the sensation of a salty flavor. And for some reason this has been noted more in men. In both sexes it's been noticed that the threshold for sugar or sucrose increases as we get older. And this sort of matches what we think of clinically when we think of older patients eating lots of sugar, that they need more sugar to actually get the sensation. Now these studies are again quite old, and they did not take into consideration the factors of smoking, which can alter taste perception, and medications. There are certain medications that will alter taste perception. So we really don't know if these are in fact true age-related changes. We do know that taste receptors decrease. We also have to consider the fact that saliva production and secretion decreases with age. And it may be that as we get older and we decrease saliva, that as we mix our food with saliva, we're decreasing the amount of exposure of the taste receptors to the chemicals in the food that will give the sensation of taste. So.
Well, I guess along with the senses we've already talked about, we might want to think of a little bit about tactile sense or peripheral sensory changes.
That's right, and there are some age-related changes there. There's been documented that vibration sense, particularly in the lower extremities, decreases. And this is very important because it has a lot to do with knowing where you are in space and may leave the individual more vulnerable for falling or having problems with safety. Light touch, knowing where your feet are, those sensations do decrease. Some of the reflexes, ankle jerk, for example, has been shown to decrease as we get older and may even be absent in some elderly clients.
Yes, I've noticed that when I've done assessments on elderly clients, that I didn't really know what an ankle jerk looked like till I started assessing younger people, because I just didn't ever come across them very much with
That's
the
right, and you
older people.
need to know that this is a normal age-related phenomena and does not necessarily indicate marked neurological pathology.
Again, it's time for a break after receiving lots and lots of information on nervous system changes in the elderly. There are review questions in the booklet to help you make more sense of what you've heard in the past few minutes. Following the break, functional, neurological, and endocrine changes are examined, as well as changes in sleep patterns, temperature regulation, and postural blood pressure regulation. Dr. Heikemper also covers common abnormal neurological symptoms and endocrine changes that come with age. First, let's have the break. Stop the tape now. Physiological age changes lead to some real functional problems for the older person. They include difficulty staying warm and trouble with a drop in blood pressure when changing positions too rapidly. Dr. Heikemper begins with functional and endocrine changes and a common complaint of the elderly, sleep difficulties. Sometimes it seems as if older people stay awake all night and sleep all day.
Sleep problems are a common complaint of the elderly. They complain that it takes them longer to get to sleep, that the quality of their sleep is not as good, that they are awake more during the night than they used to be. Studies done with the elderly have been done in sleep laboratories where they hook people up to monitoring equipment and actually record their sleep patterns during the night. And if we look at the stages of sleep, those four, stage 1, 2, 3, 4, and then REM sleep, and actually look at the amount of time that people spend in those various sleep stages, there are some marked differences between children, young adults, and elderly adults. And the most obvious thing that is noticed is that older people have a marked reduction in stage 4 sleep. Stage 4 sleep is also called slow wave sleep, and it's the deepest form of sleep that we have. It's also associated with the burst of growth hormone from the anterior pituitary. So we can say that older people spend less time in stage 4 sleep. They probably have less growth hormone secretion during sleep as well. They also show a decrease in REM sleep, the rapid eye movement sleep, which is a stage of sleep that we dream during, and is also thought to be involved in processing of information and memory. A third characteristic that is noticed is that it does take them longer to get to sleep, that sleep latency is increased. That's the period of time from when you get into bed till you actually fall asleep. A fourth characteristic is that they do go through stages of sleep more frequently than younger people do. By that I mean that they go through the various stages and they wake up more during the night. And whether this is due to neurological change or perhaps urinary problems where they need to get up and go into the bathroom isn't known. But they do have some quite characteristic changes that occur in their sleep patterns, as we all will as we get older.
Well, I suppose that's important to know because we kind of quick to go for the medicine bottle when people don't sleep well. And that wouldn't seem to be a very good solution if, in fact, these are normal age changes.
That's right. There are usually two approaches that are used for managing these sorts of problems. One is the obvious, the pharmacological treatment. For the elderly client, this is going to be a chronic problem. And as we all know, sleeping medications are sort of a short-term, temporary solution to a problem. And the better route to go is perhaps the behavioral modification, where we try to alter the environment. We try to mimic their life. If they're in an institution, we try to mimic their lifelong patterns of sleeping behavior. When do you go to bed at night? And try to allow that to occur as much as we can. We might look at diet. There are some things we can do. A glass of warm milk, taking foods which have a high tryptophan content, because tryptophan is thought to be, it is the precursor for the neurotransmitter serotonin, which is important in sleep. So there's some things we can do without turning to pharmacological interventions. And I think also acknowledging that this is a normal age-related change and that this does occur, and I think that helps to know sometimes.
Well, it's kind of interesting to find out that after all these years of advocating warm milk at night, that there's really some basis for this.
That's absolutely correct.
Well, what about other functional neurological changes that you might tell us about?
Well, temperature regulation is an integrated function of the nervous system, and that changes markedly as we get older. That older individuals are much more susceptible to problems with hypo and hyperthermia. What happens when we're exposed to a cold environment, we do a number of things to adapt to that. One is that we vasoconstrict our peripheral blood vessels to get the blood out from the periphery and back into the core of the body. We shiver to increase our heat production, and then we stop sweating. And then we might do some behavioral things like go and put on a sweater, turn up the heat, those sorts of things. In older individuals, some of these mechanisms may not be working. For example, the ability to vasoconstrict is markedly reduced, and they're not going to get good vasoconstriction in the peripheral blood vessels, which means that more blood is going to go to the skin and you're going to lose heat. As we get older, we lose our muscle mass. That's a general characteristic of aging, that lean muscle mass decreases. So if you shiver, you have less muscle mass, you have less heat produced. So they're not going to be able to generate as much heat internally. A third problem is going to be the behavioral component, that due to the dementia or other types of problems, that they're not going to go and do the behavioral things that it takes to correct the problem.
Dr. Heikemper says another factor related to hypo and hyperthermia is economic. Some elders simply can't afford to properly heat their homes in the winter or to cool them in the summer. Turning to hyperthermia, she says that when an abnormally high body temperature occurs, we do two things. We vasodilate and we perspire. But Dr. Heikemper explains that as we grow older, we don't do either one as quickly or as effectively. It takes more of a temperature change for the elderly person to initiate vasodilation, and when he does it, it's not as effective. Sweat production also decreases with age, and the older individual can't get rid of heat as well as a younger person. This is especially important to remember for people who live in warm climates. Our discussion turns to another functional change, the regulation of blood pressure. Dr. Heikemper reminds us that older people have trouble with postural hypotension.
For any of us, when we go from a lying to standing position, that's a physiological stressor. The blood in the body goes down to the feet. And sort of the way that we compensate for that is that we have receptors located in our carotid arteries, which sense a decrease in pressure. And as a result, they send a signal to the brainstem, to the medulla, that sends a signal through the nervous system to vasoconstrict, to get the blood back up, to get it moving, to get the pressure increased. Now, as we get older, that mechanism does not work as well. We go from a lying to standing position. It's going to take longer for the blood to get back up. to increase the blood volume, the blood circulating. And as a result, an older individual may have problems with dizziness and falling. So we're really concerned about this in relation to safety. Now, where is the problem? We don't really know. It could be anywhere along that rather complex integrated system. That is that there may be changes in the blood vessels of the carotid that make them stiffer and less sensitive to changing pressure. There are neurons going from the carotid to the brainstem, which may be affected by some of the age-related changes that we talked about in relation to the nervous system. And finally, to the peripheral blood vessels, which may not respond as well because of changes in receptors or whatever, to the signal coming from the brainstem, so you don't get good vasoconstriction. It's important to keep this in mind when we're counseling older people about how they should get up gradually, never jump up suddenly, concerned about safety.
Well, now, there are some common abnormal neurological symptoms, and though we're trying to focus on the normal, it might help us to understand the normal better if we could think about those a little bit.
I think that there are some changes that occur with memory and cognition, slight changes. Where you run into the problem is where you cross over from normal age-related changes in cognitive functioning to dementia types of problems. For all of us is going to be memory is a problem. It starts quite young in life. You know, the qualitative difference may be that, gee, where did I put my glasses? I can't remember where I put my glasses, versus I forgot that I wore glasses. Those are the sorts of changes that you might look for in terms of memory problems. Tremor is sort of a normal age-related change, a senile tremor. And we all know examples of more pathological tremor situations like in Parkinson's disease or Huntington's chorea, that sort of thing. Whereas all of us may show some slight tremor as we get older.
Dr. Heikemper says there is considerable discussion about the impact of endocrine changes on the elderly. They include insulin from the pancreas, hormones from the thyroid gland, and cortisol from the adrenal gland. She comments first on insulin production.
As we know, the incidence of diabetes increases as we age. So there's a great deal of interest in the normal effects of aging versus pathology on this particular system. When we look at age-related changes, there are two types of tests that are done. The first is the fasting blood sugar. Does it change with age? And in fact, there are slight changes in fasting blood sugar as we get older, that it does increase. And this begins at about the third or fourth decade that we see slight increases in the fasting blood sugar. Where we notice the greatest change, however, is when we challenge someone with a glucose load in a test known as a glucose tolerance test, be it oral or intravenous administration. And what we see here is a phenomenon known as glucose intolerance, that as we get older, our ability to dispose of the glucose decreases so that the level of blood sugar stays up higher and for a longer period of time. Now, what causes this is not really known, but there are a number of factors that have been examined in relation to this. The most obvious is, does the response to glucose by the pancreas change with age? Does the pancreas, which senses a change in blood sugar, decrease its production and secretion of insulin? And if we look at this, what we find that the number of beta cells in the pancreas do appear to change in their response to blood sugar. But there are compensations which occur because, again, this is a gradual age-related change. What you find is that there may be hypertrophy of existing beta cells to sort of compensate. So the problem does not appear to be in the ability of the pancreas to release insulin. Now, this is in the normal aged individual. The second is at the tissue level. Does the ability of the tissues to respond to insulin change with age? And in fact, there appears to be some changes in this aspect. If we look at insulin, it is a protein hormone. It involves the use of a receptor located on the cell membrane. And these cell membranes are, these receptors on cell membranes are found in tissues that respond to insulin, for example, adipocytes and skeletal muscles. And the number of receptors appear to decrease with age, that the number of insulin receptors in these tissues do decrease. One of the problems is that as we get older, the portion of our body that is composed of fat increases. And in any situation where you have increased body fat, there appears to be a decreased sensitivity to insulin. So you have to account for that part of this is due to increased fat composition of the body. Another problem appears to be that even though there may be adequate number of receptors, that once insulin activates these receptors, there's still an intrinsic problem with getting glucose across the cell membrane, that this in fact may be where the real problem lies, that even though we have decrease in receptors, that this, we don't know how many we need to get adequate insulin action, that might not be the critical variable. Another factor that may play a role in this is that as we get older and we stimulate the pancreas to produce insulin, and then we measure insulin levels in the blood, that what we find is an increase in what is known as proinsulin. If you remember that insulin is synthesized as a peptide that has 3 components to it, A, B, and C peptide composes the molecule of insulin, and that before the hormone is secreted, part of the molecule is cleaved off, the C-peptide, to give us the active form of the hormone. As we get older, the amount of proinsulin, or the part that hasn't been, that has the intact 3 components to it, increases. So we have an increase in the amount of inactive insulin hormone circulating. And whether this plays a role in this glucose intolerance is not known. What we do know is that as we get older, that much of the non-insulin diabetes mellitus can be managed by encouraging individuals to reduce their body fat, which will increase insulin sensitivity, as well as increasing activity or exercise, because exercise activity all increase the sensitivity to insulin. So many people can be managed in a non-insulin dependent diabetic by altering these 2 things in their lifestyle. Not always easy to do, but would be very beneficial.
Another endocrine problem is either hypo or hyperthyroid. Dr. Heitkamper says 5 to 7% of the population have one of these 2 problems. You may recall she said at one time it was thought that age-related problems were due to primary thyroid changes, or in effect that all older people had hypothyroidism. But she says this is not true. The distribution of hyper and hypothyroidism is just about equal.
The thyroid gland, as an endocrine organ, goes through some structural changes as we get older. All endocrine organs do. They have a decrease in viable tissue, increase in connective tissue, decrease in blood supply, some atrophy of the organ itself. These are sort of characteristic changes in all endocrine organs, and functionally they aren't that important, but if we were to look at them histologically, we would see some differences. If we look at the thyroid system, we have to take into consideration there are 3 parts to it. There's the hypothalamus, which releases thyrotropin-releasing hormone, or TRH, that acts on the anterior pituitary to release thyroid-stimulating hormone, or TSH. And it is TSH which then stimulates the thyroid gland to release 2 hormones, T3, which is triiodothyronine, and T4, which is thyroxine. And we release more T4 than T3. T4 is not as biologically active as T3, but as we need more T3, we can convert in the periphery T4 to T3. Okay, then this thyroid hormone then feeds back to the hypothalamus to shut off the secretion of more hormone. So it's a very regulated system. So what happens in this system as we age? It's been shown that for men there appears to be a decrease in response to TRH. That is, if they're given an injection of TRH, they show a decreased secretion of TSH. And why that occurs more in men than in women, we don't know. It's just one of the things that has been observed. If you look at thyroid hormone levels, T4 and T3, the actual hormones in the blood, if you have a well-nourished population of elderly individuals, there should not be any changes in thyroid hormone levels. Some of the earlier studies that were done on individuals in nursing homes whose nutritional status was not that good, and they found decreases in thyroid hormone levels, which makes sense. If we think about what thyroid hormone does, it's very much involved in metabolism. It increases our basal metabolic rate. And when we are in a state of malnutrition, we do not want a hormone around that's catabolic. And so it's sort of a protective mechanism that in those situations we would decrease the level of these hormones. But in the healthy elderly, we should not expect to see a decrease in these hormones. Now, this does not mean that there are no changes in the thyroid system as we get older. In fact, there's a very marked difference or change. As we get older, the metabolism of many constituents in the blood, or drugs or hormones, decreases, and thyroid hormone is no exception. we have decreased metabolism of thyroid hormone, which means that naturally the blood level would increase. But because this is such a regulated system, the thyroid hormone feeds back to the hypothalamus and decreases secretion. So we see two very important things happening with the thyroid system. One is a decrease in metabolism in the hormone, producing a decrease in secretion. So we do see age-related changes in the thyroid system, but in thyroid hormone levels in the blood, unless there is some pathology such as Graves' disease or thyroiditis, we should not expect to see marked changes in thyroid hormone levels.
Well, since this is rather common in the elderly, it would seem that in the assessment process that the activity of the thyroid should be one of those things that is assessed through blood examination.
Exactly, and that's very commonly done on elderly clients checking into acute care facilities. That complete thyroid tests are done, including the measurement of TRH, TSH, T4, and T3 are commonly evaluated because the symptoms of thyroid disease become manifested in cardiovascular changes, that people with hyperthyroidism have problems with tachycardia, increased blood pressure, problems of that nature. And on the other extreme with hypothyroidism, they're going to have problems with bradycardia, problems of that nature. It also has to be kept in mind that treatment of thyroid disease, thyroid problems is going to be more difficult in the elderly, that for the individual with hypothyroidism, starting them out on thyroid hormone is going to be done at a lower level and the level increased more gradually than in a younger individual because, again, of these cardiovascular effects of the thyroid hormone.
A third endocrine change Dr. Heitkamper examines is the adrenal gland. She says it is studied in connection with aging because of its impact on the stress response. Whenever an individual's adrenal gland is stressed, it releases cortisol, which has a multitude of effects on the body. Researchers are very interested in knowing if there are changes in the way the older person responds to stress.
If we look at the adrenal cortisol system again, we have to take into consideration the various components. We know that the hypothalamus releases a hormone known as CRH, corticotropin releasing factor, which acts on the anterior pituitary to stimulate the release of ACTH, which then acts on the adrenal cortex to stimulate the release of cortisol. Cortisol then feeds back to the level of the hypothalamus to inhibit further release. So again, we're talking about a very regulated system. Another component of the system from a normal physiological perspective that we have to think about is that we have a circadian rhythm in our release of cortisol. That for those of us who are active during the daylight hours, we have a peak in our cortisol level in the early morning hours at about the time that we are awake, getting up in the morning, sort of to help us out. And that this circadian rhythm runs on a 24-hour basis. And we know that we can do various things to disrupt the circadian rhythm, for example, traveling around the world and into different time zones by shift working, by doing various things like that. In our older individuals, the question is, does that circadian rhythm change? And as long as the individual has the normal cues, for example, does not have severe visual impairment, so they can tell light, dark, cycling, that they're in an environment that is normal and regulated, that they will continue to show a normal circadian rhythm that does not appear to change. In relation to stress, what happens is that cortisol levels do increase. As we get older, we still respond to stress by increasing cortisol levels. But those levels may increase somewhat slower than in a younger person. In other words, it may take a little bit longer to kick in the system, and the levels may actually go up higher and stay up higher longer and take a little bit longer to return to baseline than what we see in younger individuals. I should point out that this is probably an area that has not been well studied, that these are, some of it is sort of speculated based upon clinical blood level monitoring types of studies, and then studies in animals as well. Very much like the thyroid system, there are changes in the cortisol system. And that is, again, we're talking about changes in metabolism of the hormone. As we get older, the ability of the liver to metabolize cortisol decreases. And because it is a very regulated system, we have higher blood levels which feed back to the hypothalamus and shut off further production or secretion. So what we see is a decrease in metabolism, producing a decrease in secretion to maintain a normal blood level of cortisol.
In this segment, Dr. Heitkamper described the complexities of the elder's functional neurology and the aging endocrine system. It's time again for a break. Don't forget to check the booklet for review questions. When we come back, age changes in the cardiovascular and the respiratory systems are discussed. You can stop the tape now. In this segment, Dr. Heikemper talks about age changes in the cardiovascular and respiratory systems. As you know, the cardiovascular system in the elderly person is at special risk. 40% of people over the age of 65 die of cardiovascular disease. Another 15% suffer fatal cardiovascular accidents or strokes. 5% more succumb to other vascular impairments. Heart disease is the most common cause of hospitalization in the elderly. Therefore, it's important to know the difference between normal age changes and those that are pathological.
Now, if we look at the heart itself and how it changes, there are some things that we notice right away. One is that there is some hypertrophy that occurs, in particular the left ventricular wall. The reason for this is that as we get older and our peripheral vessels become stiffer and we have less elastin in the aorta in particular, there will be less distensibility of that vessel. So as we're pumping out blood from the heart, it's going to meet more resistance. And the way that we compensate for this is to increase the muscle mass. So what we see is that the heart will enlarge, so to speak, to deal with this peripheral resistance that has increased so that we can maintain the stroke volume as we get older. There are, of course, some cellular changes that occur in the myocardium itself. We see an increase in lipofuscin in this cell, just like we do in other cells of the body that increase with age.
You mentioned yesterday when we had an opportunity to visit that this increase by age 80 can be almost 25%.
That's right.
And so that would be almost a normal kind of thing to expect?
A normal process, at least in this culture, in this society, where we seem to have a higher incidence of peripheral vascular types of problems, atherosclerosis, things of that nature, yes. There's some other things that occur in the contractile activity of the heart as well, that the velocity of shortening of the fibers decreases. The contraction time is going to take longer. If we look at heart rate per se in older individuals, we would not expect to see an age-related increase or change in heart rate, that remains relatively stable. Where you see the biggest change in the cardiovascular system in relation to normal aging is when you stress the system. And the classic example here is with exercise, that when we exercise, we have a need to increase our cardiac output. And remember that cardiac output is heart rate times stroke volume. For most of us, what we do is to compensate, we increase heart rate. That's the component that we can change in response to exercise. As we get older, the ability to increase our heart rate decreases. So we're going to see the maximum heart rate during exercise decreasing as we get older. So that will be the major limitation to exercise as we get older, will be changes in the cardiovascular system, the ability to get blood out the amount that we would need to sustain exercise. It'll be interesting to follow groups of individuals who have been exercising more, the well-trained athletes, as they move up, as we do longitudinal studies on these individuals and follow them into their 70s and 80s. What we expect to see is that the decline in cardiac performance in relation to exercise will still be there, but the slope will be changed. It won't be as sharp as what we've seen in primarily sedentary people as they get older, but that we can perhaps alter the degree of slope of that line and not see as great a change over time.
Now, I'm not absolutely clear on when you were talking about the relationship of the heart at rest in the elderly person as opposed to exercise.
Mm-hmm.
Does that mean that it doesn't go as high or that it doesn't return to normal as quickly? Or
Probably both. It's not going to go as high, definitely. You're not going to see the ability to generate a heart rate of 140, that the maximum may be somewhere around 120 instead. Okay, but at rest, in an unchallenged system, the basal heart rate should not change with age in a normal elderly individual.
No, we have been trying to distinguish between the normal aging process, and then we have been mentioning from time to time the fact that there are, however, some very common pathological changes that increase with age. And maybe you'd like to speak about some of those.
Well, the most common one that we think about is atherosclerosis, that does increase with age, and it's going to have a pronounced effect on circulation to all the organ systems of the body. Now, we've talked about in the very beginning when we sat down this morning to talk about these things, how cell division decreases as we get older, and that we're going to have problems initiating cell division, I guess is what I'm trying to say. Atherosclerosis is a proliferative disease where we get increased cell production in the lining of the blood vessels, and eventually it narrows the lumen to the point where you start to have symptoms occurring. And this is a common problem that we see, at least in this country, as we get older. And of course, individuals who have high blood pressure are going to have greater problems with this. People who have primary hypertension, because the high pressure will cause damage to the endothelial lining and more likely to set up this process. The elderly individual also has more problems with cardiac arrhythmias. We know this from our clinical experience. The incidence of valvular heart disease and coronary heart disease also increase with age. But these are not normal age-related changes. Some valvular changes are. A little stiffness, a decrease in elastin, these sorts of things are normal, but true valvular disease is not considered a normal age-related change.
Another common problem, not considered an age-related change, is hypertension or high blood pressure. Because so many people have high blood pressure, it's often thought of as an age-related change. Many of us show an increase in both systolic and diastolic pressures as we age, but it's thought that it's related more to diet and sodium intake than to getting old. Dr. Heitkamper says hypertension is commonly related to such things as race, genetic predisposition, diabetes, and the blood glucose level of people who are hyperglycemic. She warns that individuals who have a blood pressure problem when they are young tend to have trouble in old age as well. Closely aligned with the cardiovascular system is the respiratory system. We turn our attention now to how that system changes.
Well, again, we have to start by looking at the structure of the lungs themselves. And the lungs are a very elastic tissue. They expand as we inhale, and then they recoil quite rapidly as we're exhaling. And we see that we get age-related changes in the collagen, and we get an increased number of cross-links, which are going to affect this ease of expansion and then recoil. We're going to see changes in the diameter, that it becomes wider. We're going to see loss of alveoli in the lung, which is going to change how much area we have for gas exchange. So if we look at it structurally, we see some changes as we get older. The thing about the lung is you always have to take into consideration the history of smoking, because smoking is going to accelerate the age-related changes in the lung. The most pronounced change that we see from a functional point of view is this decrease in elastic recoil, which is going to result in more air remaining in the lungs after an expiration. We can talk about different lung volumes, and when we talk about that which is left in the lung after a forced expiration, is the residual volume, and that residual volume increases with age. We also see, excuse me, a decrease, as I said, in alveoli capillary surface area, so that's going to affect movement of oxygen across, because we're going to have less surface area. And this, we also see a decrease in the arterial oxygen concentration. Again, this begins quite early in the 3rd and 4th decade and progresses into our later years. This does not appear to have real functional significance, because if you remember the oxygen dissociation curve, we have quite a range to play with before we run into functional problems. So we're at the plateau, but the arterial oxygenation has decreased. However, that does make us more susceptible as we get older to when we have pulmonary problems such as pneumonia, that hypoxemia is going to be a problem in those types of situations. There is some decrease in exercise capacity, but again, the major component to decreasing exercise capacity resides in the cardiovascular system, that accounts for the true age-related changes. It's not really due to our respiratory function.
The age changes in the respiratory and the cardiovascular systems take their toll on the aged person's ability to cope with normal activities of daily living, Dr. Heikemper talks now about some of these changes, and she reviews medication and alterations in lifestyle that may be necessary to control them.
Well, I think we can talk about specific problems that the elderly person who has, again, cardiovascular and respiratory problems. For example, individuals who are short of breath, have reduced strength and fatigue, and endurance are going to have problems. And as nurses, we need to assess these systems in terms of planning activity and rest periods, identifying those who are going to have most problems, and then planning a schedule for them. We need to help them identify what the early signs of fatigue are, what the cues are before they reach a point of utter collapse, I guess. And then we need to evaluate very carefully the normal activities of daily living in relation to endurance. What is a normal schedule like? What can they do based upon their cardiovascular and respiratory system? People who have changes in the cardiovascular system frequently have pain as well. It might be angina, or it might be leg pain due to intermittent claudication, these sorts of things. We can help people to understand what the cause of the pain is and what may precipitate it, how to distinguish angina from more severe problems such as myocardial infarction. We need to, again, evaluate what activities they're doing in relation to precipitation of pain to allow rest periods. And if they understand the early signs, then they can modify their behavior. And we need to evaluate for people who have pain what their sources of support are in their environment. Because hypertension is such a problem in our older population, we need to think about changes in activities of daily living in relation to hypertension. Many of the treatments for hypertension involve modification of lifestyle, and we need to know how to help people do this, to know how important it is to change their sodium intake, to take their diuretics, whatever, and how to incorporate these changes into their lifestyle without creating a major upheaval for themselves or for their families. We need to plan with them about their medications and when they're going to take it and how important it is for drug compliance. And then to live with some of the pharmacological effects of taking diuretics, that they are not without their side effects, and how they need to identify some of the early signs of problems, say with potassium balance, et cetera, and again, lifestyle modification.
I understand that as far as health promotion is concerned, that the best chance we have of actually improving the situation is through lifestyle modification.
Yes, we see that over and over again.
Right.
The way to maintain the best physiological functioning as we get older is to start very young, to exercise on a regular basis, to make dietary modifications as we need to, so it doesn't become such a shock, to sort of slow down those age-related changes. We can't change the normal biological changes with aging. We can't. They're normal. They're going to happen. But that doesn't mean we can't slow them down a bit or lessen their impact.
Right.
Until recent years, it was assumed that after a certain age, older persons become asexual. That is, they lose their sexuality or are no longer interested in the sexual part of their lives. If an older gentleman showed a lively interest in the opposite sex, he was labeled a dirty old man or tabbed as being cute. As far as the ladies were concerned, they didn't talk about such things. Now we know that sexuality is a part of our lives during all of our years. To be able to lead sexual lives fully and comfortably, knowledge of the physiological changes that occur in the reproductive system is important for both men and women. In men, sexual function does not cease, but it does change. Erection takes longer, and it may not be as firm. It subsides more quickly. There is a longer time between erections. Ejaculation is less forceful, and the volume is less. Sperm motility decreases, but they can still penetrate an ova. An older man can still become a father. At about age 50, the serum testosterone level decreases, and there are some sclerotic changes in the blood vessels. This may account for some of the changes I have mentioned. Some older men do have reduced sexual function. There may be less interest in sex or decreased libido, as it's called. There is increased impotence or failure to ejaculate, and increased erectile impotence or the inability to have an erection. Chronic health problems and the medications prescribed for those conditions may be the underlying causes more than aging itself. Other reasons may include boredom, fatigue, overeating, smoking, too much alcohol, psychiatric problems, depression, and fear of failure. It's possible that if the older man is not aware of normal age changes, he may think his inability to maintain an erection as long as in the past means he's failing. And if there is a significant fear of failure, the fear itself may cause him to fail. In women, the most common phenomenon of aging is menopause. Menopause is defined as the last episode of menstrual bleeding, which is commonly seen in the early 50s. Therefore, women spend about 1/3 of their lives in the post-menopausal period. The age of menopause is not related to the age when the menstrual cycle began. It's more related to the economic and social status, race, weight, height, and the number of children a woman has had. Women who smoke have an earlier onset of menopause than non-smokers. Menopause changes are attributed to a decreasing level of estrogen in the years preceding menopause. The ovary becomes less responsive to gonadotropin. There is a decrease in the length of the follicular phase, while the luteal phase remains intact. Because of a decreased negative feedback to the hypothalamus, we see an increase in the follicle-stimulating hormone, FSH. This is because if the follicle-stimulating hormone is not getting the response from the follicle it expects, it will continue to try to stimulate the hormone. Consequently, there is an increase in FSH after menstruation ceases. There is also an elevation in the luteinizing hormone level. There are decreases in estrogen and androgen. Some estrogen is present because of peripheral conversion of androgen in fatty tissues to estrogen. For this reason, we see higher estrogen levels in obese women. Because there is generally less estrogen, the size and weight of the reproductive organs decrease. The breasts become smaller, and there's some atrophy of the endometrium of the uterus. Another observable change is a mild hirsutism, a light mustache or facial hair. The incidence of reproductive organ cancer increases after menopause. There is also a menopausal syndrome in women that occurs, but not all women. This is the vasomotor instability called hot flashes. There also may be complaints of insomnia, mood changes, and irritability. However, I sometimes wonder if mood changes, irritability, and insomnia may be mistakenly attributed to menopause, because people other than menopausal women have similar problems. An almost universal problem, however, is the dryness of the epithelium or the skin, including the vaginal mucosa. These, then, are the most common age-related changes in the reproductive system of men and women. Age changes in the reproductive system do occur. It's important that the older person knows what they are so he or she can take them in stride and plan appropriate adjustments. The reproductive system is closely aligned with the urinary system, and Dr. Heikemper returns after the break to discuss urinary and renal changes. Now, it's time to take a break to review the information on the cardiovascular, respiratory, and reproductive systems. You can stop the tape now.
We talked about in the nervous system how we lose neurons. Well, in the kidneys, we lose nephrons. And remember that nephrons are the primary functional unit of the kidney. And so as we get older, we lose nephrons. And we don't really notice that because as we lose nephrons, the ones that we have remaining compensate. They hypertrophy so that they take on the function of what the nephrons other nephrons were doing before they were lost. So we have to have, if it's a gradual process, you can lose a significant amount of renal tissue before you start to see the typical clinical manifestations of chronic renal failure, for example, increase in blood urea nitrogen or creatinine. That people with chronic renal failure frequently have lost 75–80% of their renal tissue before they start to show those changes in laboratory values. But we do lose our nephrons. We have a decrease in renal blood flow, and certainly in the person who has sclerotic changes in their blood vessels, that's going to even be more reduced. We have a decrease in our glomerular filtration rate. And these sort of factors are also going to influence excretion of drugs and hormones as well. We have a decreased function of our existing tubules and their ability to excrete certain substances and to reabsorb. So the elderly are more vulnerable to salt losing problems. They're going to have less ability to reabsorb certain things when they need to. For example, sodium reabsorption during times of volume loss. When you need your kidneys to start reabsorbing sodium, they're not going to be able to do that as efficiently as in a younger person. So overall, we can say that we're losing some renal tissue and that the kidneys are decreasing in weight. Now, to move on down and to talk a little bit about the bladder, which is, of course, a real functional problem for many older people, there are some normal changes that occur, and one is that the muscle tone decreases, that the bladder itself is composed of muscle, and the muscle themselves decrease and the tone decreases. And what this is going to mean functionally is that we're not going to be able to empty the bladder as efficiently. So as a result, the residual volume that's left over after we urinate is going to increase. What this means for the older person too is an increased susceptibility to urinary tract infections, because residual urine is associated with bacterial overgrowth. So this will be a problem. Now, people who have some rather common pathological problems are going to have more problems with the renal system and the bladder and urination. And these are people who have diabetes and have peripheral neuropathy, which is going to occur, which may affect the bladder. People who have any neurological problems are going to have more problems with the bladder. In men, if we move from the bladder downward, one very common problem, and one that we might even think of as almost a normal age-related change, is benign prostatic hypertrophy, where the prostate gland increases with age. And in studies where they've looked on autopsy at the prostate gland, nearly every man over a certain age has some enlargement of the prostate gland. For many individuals, it may never be symptomatic. That as it increases, though, in some individuals, it decreases the outflow of urine and will give the classic problems of frequency, having to get up and go to the bathroom at night, and dripping and things of that nature. And usually once it causes urinary problems because of the likelihood of causing urinary stagnation and UTIs, that people will have to go for surgical correction of the problem. But that's very common. Along that same line, when we're talking about pathological conditions, the incidence of prostate cancer increases almost exponentially after the age of 40. That's a very, very common problem. And again, for some people, it may be subclinical, but men as they age need to go in and have regular checkups on the prostate gland.
I understand that in very old men, 80 and above, that prostatic cancer has a very high rate, but it proceeds so slowly that they may die of something else before that actually becomes the problem.
Prostate cancer in a younger individual is much more rapid and has perhaps a much higher mortality rate because of the ease at which it spreads in the younger individual than in an older individual.
Another change that comes with age is the decreased capacity of the urinary bladder. When the little lady says she has to go to the bathroom, it's a very real situation. Sometimes we get impatient with someone like that, but it is a real problem that they, and in many cases we, have to deal with. They may not realize they have to go until the bladder is full. By then, they have no time to wait.
That's right. Urinary problems are a major concern, both from a physiological point of view, but also from a social point of view. And so it can be have quite an impact on an individual's lifestyle.
Well, We've been moving along rather nicely this morning, and I am aware that the gastrointestinal changes with age are those in which you have a particular interest. And so I would like to give you some extra time to talk about that this morning in addition to your usual comments that you make.
Okay. You bring up the point about my obvious bias for the gastrointestinal tract because it's the area that I do research in, but also because of my own clinical experience in that the gastrointestinal tract and functional problems seem to be a major complaint of the elderly population, be it diarrhea, constipation, abdominal pain, heartburn, very common complaints. And when we go to the literature to read the research on age-related changes in the gut, there is very little. There have been very few studies done on the gastrointestinal tract. Part of that has to do with the fact that many of these functional problems are not life-threatening. The other is that it's a very difficult system to study. You can look in the mouth and you can do rectal exams, but everything in between is very, very difficult to evaluate. But we do know that there are some age-related changes, and those are the ones that I'll spend a few minutes talking about. If we look in the mouth, the most obvious thing are, as far as age goes, are the dental changes. And I'll just make a few comments about this, that there are many problems that older people have in terms of ill-fitting dentures. And some of this is related to a reluctance to go and seek out dental or oral care, that they're and the older population at this time anyway, they have a tendency to view oral changes as normal and that very little can be done about them. It also costs money to seek out dental care and the need for transportation to get to and from the dentist's office. But there is a higher incidence of caries as we get older, and they're not the type of dental decay that we see in younger people. The caries are more likely to be near the roots, near the gum level of the teeth rather than on the upper surface of the teeth. So to think that caries decreases once we get into our 20s and 30s is true, but to remember that the incidence is going to increase as we get somewhat older. And oral health is extremely important because it affects our dietary intake, and it can significantly impact on nutritional intake. Plus, the whole idea of eating and the social value and all of those things can be altered. But if we look in the mouth in terms of physiologically what happens, we already talked about taste receptor changes. We secrete one enzyme in the mouth known as amylase, which begins starch breakdown. It isn't really that important an enzyme, and it doesn't appear to change with age. If we move beyond the mouth and look in the esophagus, there's a condition known as presbyesophagus, which refers to some normal age-related changes in this structure. Remember, the esophagus is simply a long, hollow tube that food goes from the mouth down into the stomach. And as the bolus is moving down, there are a series of contractions which helps to move it along. As we get older, what we see is an increase in number of very weak contractions. They're not as forceful. It's going to take longer for the bolus to get from the mouth to the stomach. Older people may complain more about foods feeling like they're stuck, that medications may be more difficult to take. And this may in fact be related to this physiological change in the esophagus, that it just doesn't work as well. Another problem commonly seen in older people is a relaxation of the lower esophageal sphincter as the bolus gets down to it and needs to go on into the stomach. And if this sphincter does not relax, the food has a tendency to sort of get stuck and can give a sensation of discomfort to the older individual. Moving on down into the stomach itself, what do we see as far as age-related changes? The most prominent change that we see is a decrease in hydrochloric acid secretion. We become somewhat achlorhydric. We produce less acid. Now, this could have a couple of consequences if it is severe enough. One is that we have acid in the stomach for a purpose, and part of that purpose is to destroy any bacteria that we might have ingested in our food. With less acid, we may be more susceptible to bacterial contamination or enteritis related to contaminated food ingestion. And remember, again, we were talking about decreased smell sensation, so they may not know that they're eating contaminated food. Okay. With decreased acid secretion, you also get decreased secretion of intrinsic factor. Intrinsic factor is it's essential, it's very important, for the absorption of vitamin B12 in the terminal ileum. Vitamin B12 is a vitamin which is critical to the formation of red blood cells. So individuals who have decreased intrinsic factor have decreased absorption of vitamin B12 and are particularly prone to what's known as pernicious anemia. So they will have changes in red blood cell formation. Now, while we're all very aware of the anemia that may occur, people who have decreased absorption of vitamin B12 may also have neurological problems as well. And these neurological problems, once they occur, cannot be always reversed. So it's very important to be aware of this as a possible problem. Certainly, people who've had gastrectomies, significant portions of the stomach removed, people who have a history of chronic atrophic gastritis, where for a number of different reasons, autoimmune, ingestion of irritating substances, drug intake, whatever, lose the normal acid-secreting cells in their stomach. And these people are at particular risk for this type of problem because they're not going to have secretion of intrinsic factor. If we look at what the stomach does, one of the most important things the stomach does is it regulates the rate at which substances go to the small intestine. The small intestine is where we absorb everything. And it can only digest and absorb dietary constituents at a certain rate. And so it's very important that things just don't dump into that. We see that in people who've had gastrectomies and have dumping syndromes, as sort of all sorts of problems, symptoms that they have, malabsorption being an important one, because they're having substances go into the small intestine much more rapidly than they should. Does this function of the stomach change with age? And it's been shown that probably it doesn't, that emptying of solid food occurs pretty normally as we get older. However, where we do see a slight change is in the emptying of liquids, that appears to slow down. And I always like to think about this in relation to the clinical situation of the individual on tube feedings. That here's a situation where we're delivering a liquid diet into the stomach. And if we know that this is an older person, his stomach may not be emptying as rapidly, therefore the volume may stay in the stomach longer, we should probably think about our evaluating residual volumes. You know how we always check the residual volume that's in the stomach before we give the next feeding, that maybe we should expect to see a somewhat higher volume in the stomach because it's not going to be emptying as rapidly. I think the other thing, it tells us how important it is to check residual volumes in that particular type of situation. As we move on down from the stomach, we get into the small intestine, which is where all the digestion and absorption occurs. At this point, we should probably talk about the other organs of the gastrointestinal tract that contribute to digestion. And this would be like the pancreas, which secretes the primary enzymes that break down fats, carbohydrates, and proteins. The pancreas normally does not appear to change with age. We talked about the endocrine portion, the beta cells. We see some changes, they hypertrophy, whatever. But the enzyme portion of the pancreas does not appear to change with age. The gallbladder, with the secretion of bile, which is important for fat digestion, does not appear to change with age either. What we do see as we get older is a higher incidence of gallbladder problems, a higher incidence of gallstone formation. And this is actually, as in younger people, more common in women as they get older. It's thought that this is related to the fact that our serum cholesterol levels increase with age. If you have higher cholesterol, it precipitates in the gallbladder and the formation of cholesterol-type stones. And so pathology in the gallbladder may be increased as we get older, but again, normally we shouldn't see any changes in the amount or the quality of the bile that is released. If we look at the intestine now, we're talking about digestive enzymes appear to be okay. What about the absorption now? We've broken everything down. What about absorption? Does it change with age? What we see is we look structurally at the intestine, we find a decrease in the number of villi. And the villi are those little projections which have all the surface area for the absorption to occur. So we see a flattening of the villi as we get older, which would decrease the surface area. But the gastrointestinal tract is so redundant, we have so much area available for absorption, that this is probably not a significant problem. When they study absorption in the gut, they give a sugar substance known as xylose, and they monitor it in the blood and then the renal excretion of it. And the absorption of xylose, which would be a functional test of gut absorption, does not change with age. Okay? So we don't see a lot of changes in the small intestine. If we move on down to the colon and the large intestine, we do see some more age-related changes. But it's very difficult to separate out the contribution of diet and environment to changes in the colon versus normal age-related changes. Certainly functional problems like constipation are very prominent in this particular culture, but perhaps that's related to a pattern of low fiber and high carbohydrate types of diets rather than true age-related changes.
Another condition that Dr. Heitkamper says is not quite age-related is the presence of diverticula. Diverticula are very common, and most people will have the condition if they live long enough. But the reason she stops short of saying that it is a part of normal aging is because the condition is seen mostly in Western cultures. She says it doesn't occur as often in countries where individuals have a higher fiber intake than we do. Dr. Heitkamper explains that if we have a low-fiber diet, it takes more pressure to push the bolus along in the colon. When this happens, the wall of the colon is weakened and eventually little outpouches form. Diverticulitis occurs when the outpouches become inflamed. Again, diverticula are common in the elderly, but they are probably related to a lack of fiber in the diet. Dr. Heitkamper completes this section on gastrointestinal changes with age with a discussion of the liver, an important organ, especially as it relates to drug metabolism.
The liver decreases in weight as we get older, like we're seeing in so many organs of the body. However, if we take into consideration body weight when we're looking at liver weight, the change in liver weight is not that dramatic. That it parallels the change in body weight. The blood flow to the liver markedly decreases, and again, this is going to impact on drug metabolism. There are a number of enzyme systems in the liver which decrease with age, and we'll see this again in particular with drug metabolizing enzymes, that they do decrease. Other enzyme systems, while they change, don't seem to be that functionally important. The thing about the liver, I think, that's most important when we're talking about aging is the ability of the liver to sort of bounce back from an insult or inflammation. That when we're younger and we lose a significant amount of liver tissue, the liver will regenerate, and it will regenerate in a pretty normal fashion, that we will get back good organized liver tissue. The older we get, if we insult the liver or injure part of it, we still get regeneration. It's going to take longer, and we won't always get the nice regular structure that we had to begin with, that there might be some irregularities, there might be some more pronounced changes in function after recovery from injury to the liver.
This completes our tour of the gastrointestinal tract to learn what the normal age changes are and what other changes are commonly caused by other non-age factors, such as the amount of fiber in the diet. Check the review questions in the booklet and take some time to relax. We've covered a lot of material in this last section. Replay the tape if you have trouble answering the review questions. Following the break, our topic is the largest organ of the body. Do you know which one it is? Dr. Heitkamper talks about changes in the musculoskeletal system when we come back. Stop the tape now. Later in this segment on skin and musculoskeletal changes in the elderly, Dr. Heitkamper talks about decreases in bone weight, cartilage changes, muscle fiber loss, and altered gait. She also comments on osteoporosis and degenerative joint diseases that increase in frequency with age. It sounds like there's lots of good information coming up. Because the skin is the largest and most visible of the body's organs, the aging changes that take place here are also the first to be noticed. The discovery of wrinkles in our previously smooth, fresh-looking skin is an early message that, hey, we're getting older.
That's right, because the world sees the external person, and the skin is the first thing that people encounter. And I think it's not just the elderly that care about their skin, that all of us, as we enter our middle years, become very concerned about age-related changes in the skin, because it has a lot to do with how we perceive ourselves and our body image, those sorts of things. We have to keep in mind that the skin has a number of functions. One is the obvious, the cosmetic type of thing, and the fact that it's a barrier to the external world as well. And when we have deficits or breaks in that barrier, we may be leaving ourselves more vulnerable for invasion by organisms and injury. Skin changes are related to aging, but they're also related to a number of common pathological problems as well. For example, diabetes mellitus, a common problem, again, in older individuals, can result in skin changes. When we're talking about the skin, we always have to think about the environmental factors as well. The exposure to sunlight, exposure to certain chemicals may accelerate the aging process in terms of changing skin texture, of wrinkling, and these sorts of things. When we look at the skin, we remember that it has an epidermis and a dermis. And for both of these, we see some age-related changes. That the dermis is where the sebaceous glands are, where the hair follicles are. We lose hair follicles as we get older. Our sebaceous glands, while they may not actually decrease in number, many of them go into a prolonged resting phase where they don't work that consistently. So we have to take into consideration both of these layers of the skin in relation to aging. Certainly, the skin becomes drier, becomes more dehydrated. There are changes in the blood supply to the skin that, if you remember, we have an arterial, capillary, venule loop through the skin. And in some places, we actually bypass the capillaries, and now we have an arterial to venous direct connection, and so we get less perfusion of the skin. And this is going to impact, as we saw earlier, temperature regulation. It's also going to affect perhaps absorption of medications through the skin as well. A third area that might be affected by this is response to injury or an antigen. We look at sensitivity of the skin to a known antigen, and the allergic response is going to be decreased, again, because of this the perfusion changes that occur. Another important thing that happens as we get older is we lose our subcutaneous fat. It becomes smaller, and that has to do with insulating us. So we're going to be perhaps more sensitive to cold because we're not going to have quite the protection that we used to have. So there's some other changes that we see in relation to the skin. If we look at the epithelial cells and how they move up, not epithelial, but the epidermal cells as they move from the dermis up to the epidermis, we see that rate decreases. And that's going to impact on healing, that if we get injury, perhaps it's going to take longer for repair to occur because the cell turnover is going to be reduced. As I said earlier, we get decreased response to irritants. We get decreased perception of changes in temperature, touch, those sorts of things, decrease in sweat production. Another aspect when we're looking at the skin is that there are a number of very common changes in the skin, things like seborrheic keratosis, skin tag formation, and then the fact that we are more susceptible to malignant changes in the skin, or neoplasia, basal cell carcinoma, squamous cell carcinoma, and even malignant melanoma. While it is not a very prevalent cancer, has been increasing, and it's more common in adults, and certainly the elderly are at risk for that type of cancer. The thing that we have to do as nurses is we evaluate the skin. We probably are in the best position to be looking for skin changes as they occur when we bathe patients, when we do a number of treatments to them, to evaluate for change, knowing that they are at risk for injury, for trauma to the skin, the effects of decreased circulation, decubitus, ulcer, those types of things, and knowing that early detection of skin changes may affect the outcome, that doing preventative measures, again, is very important. The pathological conditions in the skin are very much related to lifestyle, to exposure to the sun, and those sorts of things. So we want to identify people at risk for having skin problems, malignancies. The only way that a skin lesion can be determined to be a skin cancer is by biopsy and histology. So any skin lesion should be reported, and it should be checked out.
I think history is so important
History.
here. What people tell you about their skin probably helps us in that assessment process.
I think it's important, too, to remember that there was a period of time when skin conditions were treated very aggressively by ultraviolet light therapy or treatment of psoriasis with tar baths and ultraviolet light. The people who have a history of these types of problems may be the individuals who are more at risk for developing skin cancer as they get older. And as we see many of these people approaching their later years, we want to be sensitive to that population.
I guess what I was thinking of too with the history was the time frame, whether it's been there all their lives or if this is something new that's
A
occurred.
change. Anytime you see a change or they report a change, it's very important. We think of that particularly with melanoma too, that many of them come from existing nevi in the skin. Many of them come from perfectly normal skin where there hasn't been a mole or anything like that, but some of them do arise from normal. And we also have to check places that are not so easily noticeable, like the mucous membranes. They may develop lesions there as well.
And I noticed a picture that you had shown us that on the sole of the foot was another spot where people may not be able to really inspect it carefully, may not be aware of this kind of problem.
I think we have to be also aware of just this normal change in the skin, the dryness, and thinking about bathing patients, and do patients need to be bathed every day as we remove the oils that are somewhat protective, and not using real hot water, not using extremes, discouraging the use of a lot of irritating chemicals on the skin, and remembering always that absorption of drugs is going to be affected as well.
The American Cancer Society has an important recommendation for everyone over 40, whether they be our patients or ourselves. They warn that whenever a new pigmented lesion appears, it should be checked. Good advice. For more information on caring for skin problems of the elderly, watch another module in this Quality Nursing Care for the Elderly series. The title is Impaired Skin Integrity in the Elderly. The video and booklet have a section on identifying skin lesions. It also has many tips on assessment and care of various skin problems, including pressure sores. Our attention now turns to the musculoskeletal system. Musculoskeletal changes are important factors in the well-being of the elderly. Limitations of mobility and the pain related to problems such as arthritis decrease the quality of life for many elderly persons. Dr. Heikemper begins with a review of structural changes.
If we look at it again structurally, we see a couple of things. One is that our bones get lighter as we get older, that all of us will have experienced a decrease in bone weight, bone density. A second area we look at is the cartilage, which you remember is on the surface of the joints, the ends of the bone that are in the joints. And there are some degenerative changes which occur in this cartilage. And that is why degenerative joint disease is such a common problem in the elderly. Again, it is such a common problem, it's almost a normal age-related change. We see also loss of muscle fibers. We talked earlier about lean muscle mass decreasing. Well, as you lose muscle mass, it's going to impact on the musculoskeletal system. And as a result, you're going to see changes in endurance, ability to do certain prolonged exercise types of activities. There are also changes that occur in the gait, in the way that we walk as we get older. Our base becomes broader, our feet are further apart, we aren't as mobile, we don't swing our arms as freely or as far back. And we have a basic overall change in our posture. We kind of slump a little bit forward and the head sort of is more downward, and that's going to give us the ideal movement for falling forward and leaves us very vulnerable for falls, is that type of change in gait and posture. We also don't lift our legs as high, our feet as high when we're walking, again making us more likely to trip. So there are some rather profound changes. There are also some very common pathological problems, and one of these is osteoporosis, which we'll talk a little bit more about when we get to nutrition. Osteoporosis, however, is not at this time considered a normal age-related change. The loss of bone is a normal age-related change, but when you get to the point where you're symptomatic and have osteoporosis, that is not a normal age-related change. And the reason for that is that it doesn't occur in everyone. The normal loss of bone does occur in everyone, but to actually cross the line into osteoporosis is not a normal age-related change. And then the second common pathological problem is degenerative joint disease.
Is there anything else you want to share regarding the perhaps muscle changes that you would like to mention a little bit further?
Well, I think when we have changes in muscle mass, as I said earlier, you have changes in endurance and ability to perform certain functions. The other thing is that there's some neuromuscular changes that occur. If we think about taking in information and processing and responding to it, much of that is sort of a reflex type of situation. As we get loss of muscle mass and neurological changes, those responses are going to decrease, that our reflexes are not going to be as well. And again, that has a lot to do with increasing our vulnerability to injury, that if we're falling forward, we're not going to be able to respond as quickly or with the strength that we would have at one time. People have been interested in this whole idea of falls because of its relationship to injury, fractured hips, hospitalization, immobility, and demise. It seems to be sort of a vicious cycle once a person enters into that situation. So people have been looking at what it takes to maintain balance. It takes good visual perception. It takes good peripheral perception of where your joints are, your tendon reflexes. And as we get older, there are changes in both of these which will make us more vulnerable. We don't know if there are changes specifically in our vestibular system. We have the vestibular nuclei that are fluid-filled, and they're what keep us upright. And so when we have a change in position, they stimulate muscle via nerve muscle, to maintain our posture in an upright position. And we don't know if there are selective neuron losses or selective changes that occur in these vestibular nuclei that may, perhaps as we get older, make us more susceptible to falling.
As you talk, it points up to me the complexity of the problems when we're thinking of the elderly. In other words, we do know that normal age changes have some implications in terms of the feeling of dizziness when one gets up because of hypotension, and then you're just now talking about these other possibilities or the thoughts about them, and to really nail down what the problem is quite a detective story, isn't it?
Well, I think it goes back to one of the basic concepts we talked about at the very beginning, which is that integrated functions show the greatest changes. And certainly the ability to stay upright and not to fall is an integrated function. And it's very difficult to determine, just like with the blood pressure, the postural hypotension, where is the problem? If we could identify that, then we might be able to plan appropriate interventions. We know that there are certain people at risk. So the epidemiological studies have shown us there are certain individuals who are more likely to fall. Women, mainly because women live longer than men, so that, epidemiologically they are more vulnerable. People who live alone, people who have visual problems, people who need to get up in the middle of the night to go to the bathroom. A lot of these types of factors can be influenced by environmental manipulation. Some patient teaching in regard to perhaps handrails in the bathroom, getting rid of area rugs, shoes, the types of shoes that they're wearing, maybe getting people over the stigma of using a cane and a walker. These sorts of things may prevent a lot of falls. We need to evaluate certain patients on medications that may make them more vulnerable to falling. Some of the ideas about dehydration and decreasing blood volume and dizziness, as you mentioned, may leave certain people at risk for problems. Certainly any drug that affects cognitive function is going to affect their susceptibility to falling.
Dr. Heitkamper adds an important postscript to her comments about falls. She says, if a person is identified as having fallen once, you should be alert to the fact that this person will probably fall again.